There are a number of major challenges that we're dealing with in the non-driver population. First off, the absence of an oncogenic driver limits the therapeutic options, and unfortunately, historically, median survival in this group is inferior to those with an oncogenic driver. There is a population, subpopulation, maybe 5%, 10%, where immunotherapy not only doesn't work, it may work to the patient's detriment. We have seen this phenomena of accelerated or hyperprogression in some individuals, which is quite frightening, where an individual might have had progressive disease and then they're treated with immunotherapy and their disease takes off. We have no way a priori of identifying those patients. Intriguingly, individuals who have been exposed to immunotherapy, and some of these include folks with hyperprogression, when they're rechallenged with chemotherapy, they may actually do fairly well. So we may actually be seeing some sort of abscopal or remote effect that makes chemotherapy work better subsequently. We need to, again, figure out what the optimal sequence is. We need to do a far better job of identifying individuals who are more likely to respond to immunotherapy agents. So PD-L1 testing has become our new standard. Certainly in the upfront setting, it identifies the 30% or so that have high levels of expression who frankly do better with immunotherapy, specifically pembrolizumab over chemotherapy alone. But I am convinced that there are other markers that can predict who's likely to benefit. And tumor mutation burden is just one example. And now with next generation sequencing, we can identify the number of mutations that each individual has. And there are retrospective studies that show that the mutation load can correlate with the response benefit to these new agents. And those who are lucky to respond, we have no idea how long to continue these treatments. There are increasing data to show that treatment beyond 2 years probably doesn't necessarily benefit these individuals any further. So there are now trials that are looking at those who have had a response, and are comparing 1 year to 2 years to indefinite treatment, obviously with the option of resuming treatment should disease ultimately progress. But these are all unanswered questions. Obviously, for those who've enjoyed a response, that's a good dilemma to have. I think the bigger challenge, obviously, are those who don't respond all that well, and whether some sort of combination immunotherapy strategy or unique combinations between immunotherapy and chemotherapy can overwhelm or overcome intrinsic resistance. That, to me, is probably the biggest challenge.